So this next portion will be focusing on obstructive versus restrictive disorders in the lungs. Obstructive disorder that we'll spend most of the time talking about is asthma. And the key is to understand the difference between obstructive and restrictive disorders and looking at one essential component of a spirometry result to try to figure out if you're dealing with an obstructive or restrictive disorder. Because just like when we talked about the neuro thing, sometimes people's presentation for either disorder could be shortness of breath with a cough. And it will take you some figuring out to decide which problem is which. So the first thing we need to understand, and this corresponds with slide 30, is lung volumes that can be measured and what can be used in order to determine if something is a restrictive or an obstructive disorder. So each person has about 4 to 6 liters of a volume that they could get into their lungs. This could be 6 liters is more for men, 4 liters closer to women, but it's somewhere in there. These volumes can be divided. Some of these are potential volumes, like obviously we're not circulating 6 liters of air all the time. Most of the time, what you see here, this wave, is what is our usual relaxed respiratory lung volumes, or what we call our tidal capacity or tidal volumes. If you've ever worked in intensive care and they're figuring out tidal volumes, they're thinking about how much air people normally move back and forth with a normal, quiet respiratory effort. So usually you breathe in and out somewhere between 400 to 800 milliliters of air with each breath. Depends on the size of the person. And that is what you're always moving. However, there's certainly a lot of reserve ability depending on what's going on with you if you've increased your activity level. So there's an inspiratory reserve volume, an extra, upwards of 2 to 3 liters of air that you could potentially get into your lungs if needed. And therefore we have to have an expiratory reserve to match that. So there's our inspiratory reserve. This is the inspiratory reserve volume, and this is the expiratory reserve volume. If I were to measure the tidal volume and the inspiratory reserve volume, that would be my inspiratory capacity. I could measure the tidal volume and the expiratory reserve volume, and that would be my expiratory capacity. If I measure them all together, my tidal volume and my reserve volumes, that's my vital capacity, how much air I can manage to move in and out at the most. You always have a small volume of air that stays in the lungs, sort of like the end expiratory pressure because of our surfactant. That's always there. We can't empty our lungs completely there, which is good, obviously. That's what you did. So this we can't really measure. It's a mathematic problem based on sex, size, weight, etc. And this amount of air you're moving, I could calculate your residual volume. Your total lung capacity is your vital capacity plus your residual volume. So yes, those volumes do come up on that exam. So spirometry can be tested. So say you have this patient with prolonged cough and shortness of breath. You don't have an infection to explain it any longer, or you never did. And it's hanging out, it doesn't get better. So one of the things you can do to try to figure out what the problem is to do spirometry testing. And there's all kinds of things that are tested then. You're testing the total lung volumes. You're watching how air leaves the lungs to be seeing if there's any trapping of air. You're seeing what the challenges to allergens. Do they have decreased ability to move air in that instance? There's all kinds of things you're measuring. But one of the key things that we're going to talk about is how to tell with just 2 of the volumes the difference between obstructive and restrictive disorders. So an obstructive disorder has to do with the tubes, those conducting tubes. The tube is more narrow and the tube is collapsible. Like we talked about, if there's too much pressure inside the chest, then during expiration, it can be easy to collapse the tube before we wanted it to, and we can have air trapping. Whereas a restrictive disorder, there's nothing wrong with the tubes. The tubes can get the air in. It's that the lungs aren't as compliant. So that spongy lung parenchyma doesn't expand and open to accept the air as well, because something's wrong with that tissue. And if that's the case, then it's harder to inflate the lungs, even though the air could move just fine if we could. So the problem isn't the tubes, it's the parenchyma, and those are restrictive disorders. So one of the things you can even do this in an office by measuring a peak flow, at least over time, not the initial diagnosis. One of the ways to tell between an obstructive or a restrictive disorder is to look at the difference in this particular ratio, forced expiratory volume over a second divided by forced expiratory capacity. So forced expiratory vital capacity, or FVC, is giving you a rough estimate of the amount of air that can be moved in the lungs. So this is giving you an idea about compliance. So I would expect that with an obstructive disorder, there's no change in the compliance of the lungs. There's no change in the lung parenchyma. There's no change in its collagen and elastin fibers. So I should be able to expand the lungs as much as I can. So that should be the same. Forced vital capacity or forced expiratory vital capacity for someone with a restrictive disorder, they have a decrease in lung compliance because of a change in the elastin and collagen fibers of the lungs themselves. So I would expect this volume to be lower. If someone has, when I'm measuring forced expiratory volume in 1 second, I'm trying to see how much air they're able to move over a short period of time. And if that, because I'm forcing them and potentially increasing the pressure in the chest, when I do that, does the airway collapse? So I'm looking for air trapping, airway collapsing, and I'm looking for a decreased flow rate because of a narrow tube. So if I have someone take a deep breath, as deep as they can, and blow it hard and fast over a second, that volume would be decreased with a narrowed and collapsible tube, such as with asthma or COPD. So I would expect that the lung compliance hasn't changed, but the forced expiratory capacity is decreased because of the narrow and collapsible tube. And so this ratio is decreased. With a restrictive lung disease, we know that the forced vital capacity is low. The forced expiratory volume will also be low, but only because I can't open up the lungs as much. It's not because the tube is narrowed or collapsible. So they're both low together. So the ratio is the same. The problem is they're all together low. Whereas this is, the lungs can open, they're compliant, but I can't move as much air through a narrow tube, a narrow collapsible tube. This is a very, very important thing to understand. So if a patient who has cough and shortness of breath and maybe an increase in oxygen requirements or something that's going on with their respiratory system, and I want to know if it's an obstructive or restrictive disorder. If it's a restrictive disorder, there's an overall decrease in lung compliance, so all lung volumes are low. But if I looked at the ratio between volumes, they would be normal because they came down together. With an obstructive disorder, the tubes are narrow and collapsible, so my forced expiratory volume will be significantly lower, but I haven't changed the compliance of the lung tissue itself, so the capacity hasn't changed. So it's just the FEV that's low, not the FVC, which means the ratio decreases. So be sure you got that. If you don't, please let me know. So asthma is the
obstructive disorder that we're going to spend some time on. Asthma is multiple symptoms, multifactorial. So there is a role of the inflammatory mediators. Asthma is characterized by bronchospasm, increased mucus production and inflammation, as well as airway remodeling because of this continued inflammation and injury. So there tends to be increased ATP or allergies, increase in IgE-mediated reactions in people with asthma. So we didn't get a chance to talk about the different types of hypersensitivity reactions this semester. But one of the hypersensitivity reactions is responsible for allergies. And for some reason, IgE, the type of antibody, sensitizes mast cells, could be anywhere, but in the airways in this particular instance. So the IgE is responsive to a particular antigen. For people who have asthma, it could be cats, environmental allergies, dogs, whatever they're allergic to. If they're exposed to that antigen or allergen trigger, there's an IgE connected to this mast cell, the mast cell will degranulate, which means it will release histamine, leukotrienes, as well as tumor necrosis factor alpha. So the histamine, we know what histamine does when it's released, and that is an increase in vasodilation and an increase in size of capillary pores, allowing fluid and serous exudate to develop. So we end up with bronchospasm, cough, inflammation. And that's what happens when a person who has asthma is exposed to their trigger, then they get that overwhelming response. But over time, the more that occurs, the release of tumor necrosis factor alpha contributes to the airway remodeling because it increases production of fibroblasts in the airways and increases the amount of mucus cells that are available. And so the airways are not as easy to open, they become narrowed, and they have more and more ability to increase mucus production. So over time, asthma can get worse and more severe. Certainly there are other parts to asthma in terms of its development. There is a huge allergy component, but these people will have the same response to other allergen triggers like pollutants, cold air, and other bacterial viral infections will increase this response. And it's usually described depending on how often the patient has symptoms. Other obstructive airway diseases that we talk about have to do with inflammation and fibrosis of the bronchial wall. So asthma also caused inflammation and fibrosis of the bronchial wall, but also had a huge bronchospastic component. Other obstructive diseases don't have that as much as they have inflammation and fibrosis of airways. So other types of chronic obstructive pulmonary disease, or COPD, can be chronic obstructive bronchitis or emphysema. Those are both types of obstructive disorders under chronic obstructive pulmonary disease. So emphysema occurs because protease enzymes between this clump of alveoli are broken down, and we lose surface area for gas exchange. And we have increased air trapping in these air sacs that used to be these lovely grapes of alveoli. Chronic obstructive bronchitis means we have chronic inflammation, irritation of the bronchioles themselves. So if the person has emphysema, this could be activated, this activation of proteases between alveoli. This could happen because of a genetic disorder, and in that case, the distribution of emphysema is a little bit different. Most often, this occurs because of smoking history that triggers the breakdown, triggers the proteases. And so, because there's excessive air trapping in these alveoli, the person gets a barrel chest. Their work of breathing is increased, and so they lose weight. This decreased ability to exchange gas, there's more air trapping and less air movement, so their lung sounds are decreased. This increases pressure in the chest, which is why increased pressure in the lungs can put pressure on the pulmonary artery, leading to right-sided heart failure, which is what we talked about last time. So this is very debilitating and can lead to hypoxia and cor pulmonale. Chronic bronchitis also commonly related to smoking because of the chronic irritation and inflammation caused by cigarette smoke. Again, they could have barrel chest, short of breath, but their lungs have more rhonchi because you can hear the mucus instead, and they have more sputum production. You could have both together too. And then just to briefly mention some of the interstitial diseases. So restrictive lung disease means that there is decreased compliance of the lung parenchyma. We've lost some of that spongy tissue. Instead, because of inflammation, it's become fibrotic, and so it's harder to inflate the lungs. All the volumes go down. So some of those disorders are sarcoidosis, lung diseases from occupational exposure like asbestosis, hypersensitivity pneumonitis. This is partially the issue that's occurred with some of those vapors who had a diffuse flash pneumonitis, or other toxic drug exposures. So the whole lung is inflamed.